But when they started dying, things are changing now. So the India and Pakistan, because there are some areas inside the village there, they are too conservative. So, but they started getting problems. So I think it's also, they're also coming on board. So Mr. Muhendan's second question is, you're here and we really embraced. We embraced vaccination, we are here. We all embraced the vaccination wholeheartedly, and I think there was no problem. Then when it comes to malaria, like me, I do a lot of outreach, and some of my other sheikhs, we do a lot of outreach. But there is no sheikh who can do an outreach without a tent. You know a tent? These mosquito nets that are tented. You must come with a mosquito net. It must, it's a rule, it's a must. It's a regulation. You must come with a mosquito net so that you don't become a risk factor to the rest of your colleagues. Otherwise, I think we've not had any report that Muslim women and children are not sleeping in what? In mosquito nets. Apart from the mischievous, those ones who are using the mosquito nets for the poultry farms, that one doubles as a criminal. I think there are those cases there. So we are very, very grateful, and we shall embrace the malaria vaccine wholeheartedly. May God bless you.
Thank you. It's a great question. Alhaji Kayondo Bashir, and we also congratulate you for the new title. And now we are left with one of our panelists, that is Dr. Richard, who is the DHO of Rangavu District. And on our table, we have two questions for him. The first one is, what strategies is the Rangavu District employing to increase community demand and coverage for yellow fever, measles, rubella, tetanus, diphtheria, and hepatitis, and the hepatitis B birth dose, that is the first dose, which have historically faced low uptake. We saw it in the data here. 2, how is the Rangavu District planning to address vaccine hesitance and misinformation on vaccines and immunization? Thank you.
Thank you very much, moderator, minister, and the distinguished guests here. Rangavu is a little bit, of course, one of the main districts in the region, we all know that. But when it comes to demand for these vaccines, what we have been doing as a district is to, of course, we assess demand through utilization of the services. And this is data-driven assessment. So as a team, we use our data to look at the various antigens, and we look at sub-counties, we look at health centers, and we assess the utilization. And the utilization data tells us about demand for the service in those respective communities. And therefore, we use that to employ very specific interventions in some various communities that involve. Rangavu is predominantly, we have very 3 distinct communities, the upper part of the mountain, where we have like one tribe almost. Then we have the lower part of Rangavu. Also, we have specifically dominated by another tribe, and the upper part, which also has its unique characteristics. And as a team, we did to try to understand why low uptake or utilization in some specific areas, and we came up with some of the root causes. And one of the things we understood was a health system related challenge. And in the health system, we saw some health workers actually didn't know how to manage the immunization, right from ordering vaccines, documenting them, transporting them, and that was a big challenge. Documenting, you can have the numbers covered, but documentation becomes a problem. Then in the health system, we also saw issues to do with the cold chain, where some facilities had no fridges, and therefore the communities had to travel a longer distance to access the services, or the health team have to travel a longer distance to pick the vaccine from the nearest health center or the fridge, and therefore causing delays for people. And what we did as a team was to, one, is to train health workers. The HOMC has been very supportive in that area. She has been very actively involved in training health workers, not only on how to actively participate in this, but also how to document and make sure we report accurately. Secondly, we also did document and submitted to Ministry of Health some key gaps, especially when it comes to cold chain. One of the things that we are so happy to report to that over 5 facilities were able to receive new fridges, and including the one which I think was last week, that is the hand. We are so grateful. So this is now increasing access of vaccines to the communities. Second issue is about, of course, the misconceptions and those myths in the communities which has been affecting. We saw some pockets of our district where we have basically, most of them are, fortunately, are not related to cultural practices, but there are some religious sects, the new ones which are coming, not the next sects. They have very strange beliefs, and we were able to pick them during campaigns. Like people go to the household that will refuse, but the security team has been very supportive, and we have been able to pick them out and support them with information. But importantly is we continuously engage them through the media, and we thank the office of RDC and our politicians here who have been able to give them information. But additionally, we are beginning to use people who have really embraced the vaccination. Those are the influencers. So what we do is that we use them to give information to the communities instead of us, the health workers. We have very active people who have participated. One of our health security chairpersons, that is Kateba, those of you who know Kateba sub-county, is one of the key influencers. We use him a lot, and he has been very supportive. I remember in this sub-county, we lost somebody died because of hepatitis B, complication of hepatitis B, and did engage us, and we had a very huge activity in this sub-county where we were able to reach very many more people with the vaccines in those areas. The health communication strategy, and the social media now is one of the areas where people can misinform. Just like my colleague was saying here, if we are not very keen, if we don't take part in those discussions on social media, we may leave room for those who have very negative information to over-dominate. And I can tell you, there was a time I have a similar platform in the district, where some people actually came to misinform the community. And I went to the inbox of the administrator. They were having some weekly Zoom meetings. So I said, I requested to be added to the program. Particularly, the aim was to give the right information. I can tell you after that session, those misinformation ended and the platform remained very calm. And another thing we have been doing is surveillance. Surveillance, we know that we have one of the things we can detect whether our vaccination program is taken very well is if we're able to do surveillance for those vaccine preventable diseases, measles, and so on. So we have been doing surveillance to inform, particularly the health system, because we know that if you have an outbreak of vaccine preventable disease, it actually questions our quality of vaccination. It questions our cold chain system. It questions what we do, particularly as health workers, because you may find the data will say we have had very high coverage, but again we are getting outbreaks. Why? Probably we don't give a potent vaccine to this health worker, to the community. So we have been doing active sites and surveillance, and we're able to investigate cases of rash for measles and rubella, so that we improve. That's what we've been doing to improve demand. And on the vaccine hesitancy, we all know that vaccine hesitancy is how the community will perceive the delay to uptake our vaccines, or they maybe refuse completely.